Welcome to NIOP C511, Nerve Injury and Dysfunction. In the previous presentation, we talked about the causes for weakness. Neurologic inhibition or dysfunction will be the emphasis for this presentation. We'll talk about the multiple locations where nerve conduction can be impaired, everywhere from the brain to the peripheral nerve. We'll also talk of non-conductive reasons for clinical weakness. These mechanisms of neuroreflexive inhibition that have been described in the literature affecting our patient's strength. If we look at this diagram, we see a spinal segment with a horizontal section through the spinal cord. If nervous tissue is impaired at the level of the spinal cord or the brain, we refer to that as myelopathy. Conduction can also be impaired along the dorsal root, primarily affecting sensation, or the ventral root affecting the motor function, or along the combined root, which we would refer to as a radiculopathy. The majority of the cervical and lumbar nerve roots enter into plexes prior to them becoming peripheral nerves. In these plexes, they mix and match with adjacent root levels, and if a plexopathy occurs, it will be a mixed pattern, something in between a radiculopathy and a peripheral neuropathy. In myelopathy, we see altered reflexes, hyperreflexia in our deep tendon reflexes, and upper motor neuron signs, like positive plantar responses, such as Babinski, upper extremity upper motor neuron Hoffman's sign, and clonus. Altered sensation may occur in more than one limb in a non-dermatomal pattern. Altered motor control is also seen primarily in ataxia. The progression of myelopathy typically starts with flaccidity, followed by increased tone in certain muscle groups in a flexor or extensor pattern, leading to spasticity. When the bladder is affected by myelopathy, it presents as spastic retention. In an individual with spastic retention, such as a spinal cord patient, this can lead to autonomic dysreflexia. If the patient is not catheterized, the bladder overfills, sending urgent messages through the sympathetic nervous system, creating a crisis of blood pressure. Atrophy is typically not evident in myelopathy initially, especially when compared to lower motor neuron lesions. The tone and spasticity seem to preserve some of the muscle bulk, but this will waste over long-term myelopathic conditions. The phenomenon of pain is independent of myelopathy. Early in my physical therapy career, I sent more than a couple patients with abnormal upper motor neuron findings to neurologists and physiatrists, only to be told that these signs were within normal limits. When should we send them to the neurologist? Significant upper motor findings are if two or more of the following are present. Clonus of greater than 3 beats, up to 3 beats being considered normal. Deep tendon reflexes that are markedly brisk, rated at 3+, or initiate a clonic response in the tested muscle, rated at 4+. An upgoing toe response in our plantar responses, such as Babinski, or a positive Hoffman's sign, thumb flexion upon flicking the third finger. In the presence of 2 or more of these findings, refer back to the physician. These videos are of a patient who had upper motor neuron findings. She was unfortunately found to have MS. In radiculopathy, we see damage to the axon or the anterior horn cells at a particular nerve root level. Atrophy, which is usually not evident in the early phases of myelopathy, is often apparent within 2 weeks of nerve root compression. Radiculopathy can occur with or without pain. In radiculopathy, we see altered reflexes, which are decreased or absent at the associated root level. We may find paresthesia roughly within that level's dermatome, or true numbness, sensation loss, but it will tend to occur in an ill-defined small area in the distal aspect of the dermatome, where there is minimal overlap of adjacent segments. Altered motor control in the form of fatiguing weakness of key muscles of that level is found with moderate compromise, but in total compromise of the nerve root, we may have a marked weakness which is not fatiguing. Kobayashi's work on experimentally induced radiculopathy demonstrated biochemical changes occurring within 1 week of nerve root compression, indicative of Wallerian degeneration. Prolonged compression of nerve roots is believed to lead to permanent loss. Exactly what prolonged compression means varies, but in my clinical experience and speaking with neurosurgeons and orthopedic spinal surgeon, ranges from 4 months to a year are typically cited. If your patient has had sustained nerve root compression approaching these deadlines, it's important to get them a surgical consultation. Fasciculations, or small twitches in part of a muscle, are indicative of a lower motor neuron problem, usually one that's been around for a while. In peripheral nerve injury, there are altered reflexes, which are decreased or absent, altered sensation, which can be paresthesia within the dermatome, or distinctly bordered numbness in the pattern of the dermatome. This is much more obvious than the sensation loss associated with radiculopathy. The distinct borders and the large area do not evade the patient's awareness and are easy to detect with clinical testing, whereas altered sensation in radiculopathy is frequently not noticed by the patient, and careful testing is needed to discover it. Altered motor control can occur with fatiguing weakness to complete motor loss, depending on the damage to the nerve. In peripheral nerve injury, we need to remember there are a few muscles out there that are supplied by multiple peripheral nerves, pectoralis major, brachialis, and adductor magnus among them. In these muscles, the pattern may be a little bit less clear when one of the two peripheral nerves are impacted. Pain is independent of peripheral nerve compromise, although in peripheral neuropathy caused by vascular or chemical damage to the nerve, it is quite common. Cauda-equinal syndrome is a type of peripheral nerve injury. It occurs with large or centrally located lesions, typically disc herniations or space-occupying tumors. In Cauda-equinal syndrome, there is altered sensation in a saddle distribution. Paresthesia is usually greater in the region around the anus than in the genitals. Since most of us aren't doing detailed sensory examination in this region, I typically ask my patient, how does it feel when you wipe yourself after having a bowel movement? Does it feel normal or kind of funny? Motor control is affected in Cauda-equina through bowel and bladder dysfunction and sexual dysfunction. The bladder is the most sensitive and can present with either retention or incontinence. Since bladder control is a complicated neurologic phenomenon involving sympathetic and voluntary control, along with complex sensory integration, it's difficult to predict. However, bladder retention is more common. Pain is independent of Cauda-equinal syndrome. However, they often coexist, especially in large disc lesions, where there's a great deal of inflammation. Mechanisms of nerve injury. that can occur at any of the sites we previously discussed are compression, traction, transection or cutting, or ischemia. In a peripheral nerve injury that is due to short-term compromise of the nerve, seconds, minutes, maybe into a day or two, there is no sustained damage. This grade of injury is referred to as neuropraxia. And in this, we see that the endoneurium, the myelin sheath, and the axons are all intact, although they have been mildly compromised. They will bounce back and function normally after a short period. A more serious grade of injury, axonomesis, involves longer-term compromise, days and into weeks, where the axon is significantly damaged, the endoneurium sheath is intact, but the body will respond with chemical changes and Wallerian degeneration and Wallerian regeneration within that intact sheath will occur at the painfully slow rate of 1 millimeter per day, more or less. The most serious peripheral nerve injury is neuronemesis, where the endoneurium is damaged, in this case transected. In these cases, recovery is incomplete. Wallerian degeneration occurs, but since the endoneurium is not intact, there's nothing to guide the regeneration of the nerve, and often a neuroma will form and the target organ or muscle is never reached. A neuroreflexive weakness does not involve compression, traction, ischemia, or transection of any nerve. There are a number of these described in the literature, one of which, described by Travell and Simons, are trigger points. Muscles affected by trigger points are in a sustained, shortened position and have less ability to produce force. They're also readily fatigued and may have altered reflexes due to pain inhibition. The work of Julie Hydes demonstrated neuroreflexive weakness associated with low back pain, affecting the multifidus muscle in the lumbar spine. They measured differences in cross-sectional area, showing a loss of muscle bulk. They saw fiber type changes from type 2 to type 1, along with an increased fibrofatty infiltrate within the muscle. There were noted decreases in endurance without significant strength changes, and they deemed that these changes were not due to disuse atrophy or spinal reflex inhibition. Vladimir Janda described a phenomenon of pseudoparesis, where there is regional hypotonia, altered motor control, weakness, typically rated at a 4 out of 5, which is not fatiguing, potential changes in the EMG activity, and a lowered threshold for synergistic muscle recruitment. Stretch weakness, also described by Janda, but as well by Florence Kendall and Shirley Sarman, is attributed to length-tension relationships within the muscle, whereby the muscle's resting position is excessively lengthened or stretched, and its force-generating capacity is reduced. Tightness weakness is described by Janda, whereby there are chronic adaptive changes in the muscle resulting in shortness and altered length-tension relationship, suboptimal length-tension relationship, and decreased force output. The facilitated segment is something we talk about more extensively later in the curriculum. It's an osteopathic term. One of its original researchers was Irving Core. They describe a phenomenon where there is altered motor control affecting certain muscles and their ability to produce a contraction. They will often be found to be non-fatigably weak. However, these muscles are abnormally activated or facilitated. Because of this, there's often a loss of range of motion within that muscle, and even abnormal joint stresses due to discoordination, the inability to produce strength out of the muscle, and the inability to fully relax the muscle. This is also associated with altered autonomic function. This is also associated with sympathetic changes observed in the skin and in abnormal localized patterns of sweating. It is proposed that even the nutrition to the target organs of the level of a facilitated segment are impaired by this dysfunction, predisposing it to localized tissue breakdown. Facilitated segment is also associated with an increase in pain sensitivity. Arthrogenic weakness, originally described in 1965, was observed in the knee, where intracapsular joint swelling inhibited the muscles about the joint. Reciprocal inhibition is a phenomenon originally described by Sherrington, where antagonistic muscle activity decreases the force output of the agonist. The phenomenon of deafferentation, or the loss of sensory input, was described by Bullock-Saxton in 1994. In these studies, an ankle sprain injury was observed to alter ipsilateral gluteal muscle function, the proposed mechanism being the lack of afferent input in through the limb altered the motor output. How much do we have to squeeze a nerve before it starts to produce strength deficits? This information is extrapolated from the polio research of Sherrard in the mid-50s. He noticed that if the virus attacked less than half of the motor cells in a patient, clinical weakness or paralysis was typically not observed, concluding that a considerable portion, in his estimation between 40 and 60% of motor cells or axons had to be damaged before clinical weakness could be detected. When a nerve is compressed, there's a lack of available motor units to sustain that contraction over time. Initially, they may have a strong contraction. However, when the initial motor units fatigue, the patient will be unable to find functioning replacement motor units, and therefore force reproduction will decline. We call this fatigability. Fatigability is a key clinical phenomenon we will focus on in our motor testing.